So dysrhythmia means difficulty rhythm or abnormal rhythm, right?
Yeah.
And so when we look at what's abnormal, we have to understand what's normal first, and so that's what this part is going to go through. Some electrophysiology. We just went through this horrible thing with the sodium potassium pump, but we know that they work off of the myocardial cells. You have heart cells themselves, contractile cells, right? Then you have pacemaker cells that produce the energy, and we'll get through all these, the different types of cells, but it's not really important right now. But through this process is the way that the heart contracts. And just a picture for the sodium potassium pump. You know, we have these channels that we just sort of tried to stumble through, or I stumbled through, and so you have sodium potassium leaving the cell to initiate the contraction, right? And so you make an environment where you have less positive or negative, and then positive, right? To create that. It's called polarization. So you're polarizing, you're charging or you're polarizing. You get into this state, and then once we start contracting, or we start these cells start to conduct, then they depolarize. The other term that you might hear me say is fire. The cells fire, or the SA node fire is depolarizing. The true term is depolarization, but they're interchangeable. So if I say, oh, the SA node fired, that means it's depolarized, all right? If we have depolarization, what must we have? I think you said it, I just didn't hear it. Yeah, if we have depolarization, if we discharge, we have to recharge, or repolarization, correct? Okay, so those are the two things that we look at, and when we do this, just like we did, we make inside the cell becomes more negative than outside the cell, and it creates this chemical energy. So you have a resting state where everything's equal, correct? So you have positive and negative outside. You have sodium and potassium in the sodium potassium pump, and it begins to, something causes a stimulus, and then it depolarizes or stimulates that cell, that conduction cell. All right. So you have this depolarization state where it starts, and we'll get to this in a minute, and it'll be a review for you. But where it starts on the ECG or EKG is that the P wave. So a normal, and we're all familiar with this, a normal EKG complex looks like this. You have a P wave, Q wave, R, S, and then T. That would be, besides the poor drawing, that would be a normal EKG complex. So it starts here with this elevated P wave. Let me fix that a little. And what we'll learn in interpretation is the meaning of each one of these, and that's the review part. We already know. So does anybody remember what the P wave signifies? I just can't hear you. Yeah, the SA node depolarization, right? So the SA node depolarizes. What about the QRS complex? Right, the ventricles depolarize. The T wave. The QRS, the ventricles depolarized. And you have to have what? Repolarization, right? Repolarization of the ventricles. But we'll review that in a minute, okay? So when you have depolarization, you have to have repolarization, okay? And it just creates this environment now where you a positive and negative environment inside these conducting cells to provide the chemical stimulus, the chemical energy that we have. Okay, this is very important. Depolarization, it's not the same as contraction. Remember, the EKG only represents electrical activity of the heart, right? There's no mechanical representation of the heart on the EKG, just electrical. Very important, because you have electrical activity and then you have mechanical activity. What's the mechanical activity of the heart? Contraction, right? Okay, we'll look at this rhythm here towards the end. Pulsus electrical activity, or PEA. That's a state. PEA is a state where, when you're looking up at the monitor, it looks like a beautiful sinus rhythm. It's perfect. Okay, but the patient doesn't have a pulse. They're in PEA. The latest thing I read on PEA is in hospital. It's a lethal rhythm because you don't have a pulse, correct? Patient's cardiac arrest. Only has a 5% chance of survivability if they go into PEA inside the hospital. That essentially means with the drug in hand, okay, epinephrine in hand, to try to stimulate the mechanical function of the heart. Because they have a good, perfect electrical activity of the heart. They just don't have any mechanical. They don't have contraction. So something's wrong with the muscle where it's not contracting. Okay, where it won't contract. So depolarization is just like it says here. It's just an electrical event. Okay, EKG is just a measurement of the electrical activity of the heart, and then you have repolarization, or a recovery phase, okay? And it's returning back to its resting state. So you have these different phases that run through that we'll learn a lot more about once we get there in cardiac physiology. But if we look over here, we have, it starts at phase 0 and goes to phase 4, okay? So you have these different phases. If this one phase, if this from depolarization to recovery took place in 1 second, then it would be like 60 seconds or 60 beats per minute, right? But our heart beats more than 60 beats per minute, most of them, okay? So this whole thing takes place in less than a second. Some of these take place very, very fast. We were just stumbling through that influx of sodium and influx of potassium, and those take place in milliseconds. Okay, that phase. So we won't really break down the phases here, but just the big ones, the electrical phases. Okay, and then back to the resting state. The ST segment represents ventricular repolarization. The same way with the T wave. So this is the ST segment. So this from here to the end of here is ventricular repolarization. So the ventricles are repolarizing, returning to that resting state to get ready to depolarize. It's just one event. It's resting, depolarization, repolarization, resting, and that all the way through it. Because we have the systole and diastole, right? Systole is contraction, diastole is rest. Anyway, it recovers through. During the EKG complex, you have a refractory period, and this is important in EKG interpretation later that we look at this refractory period, because we will concentrate on this R wave. See, we have the P wave here, represents atrial depolarization, okay? Not contraction, but atrial depolarization, okay? This PRI, this space that's in between the P wave and the QRS complex is where your AV node takes place. Because this is all time that goes through here. Time and amplitude. The QRS complex is this entire complex here, but it's broken down into three parts, which is one is the Q wave, QRS, right? QRS. By definition, the Q wave is the first negative deflection off the isoelectric line. And we'll back up to this. Okay? Iso meaning what? Yeah, neutral. So it's just this invisible line about the level of the P wave. Because we just looked at this waveform. That's poor drawing. So this would be 0, correct? If we were measuring volts, this would be 0 volts. So this would be isoelectric. Essentially, it would be neutral. There's no response to it. Okay. So the Q wave is the first negative deflection. The R wave would be the what? The first positive deflection. And then the S wave would be the second negative. It really is that easy. And not everybody has Q waves, but if they have a Q wave, it's the first negative. R wave is the first positive. The S wave is the second negative. The reason that we want to look at this refractory period, because when we get into a dysrhythmia called SVT, supraventricular tachycardia, sometimes they do what's called a synchronized cardioversion, where the monitor, the EKG monitor itself, will focus on this R wave. And it will literally, the machine will put a dot on top of the R wave. Because what it's trying to do in that synchronized cardioversion is to deliver energy into the relative refractory period over here in the T wave. In this, so the absolute, it's broken down in this one right here, this absolute refractory period. I remember this by absolute will not conduct or absorb or take in energy. Okay? Absolute will not take in energy. Now, or a stimulus. So, if you read here, the cardiac cells cannot be stimulated to conduct an electrical impulse. Okay? No matter how strong. Now, never say never, right? Or always. So, if I'm out playing the greatest sport in the world, golf, in a lightning storm, right, and get struck by lightning, that's enough to overpower the stimulus, okay? I mean, that's a gazillion volts. So that's going to overpower it. But this is just talking about common stimulus here. Okay, so during the absolute refractory period, there is no stimulus to be conducted through here. So, if we're to synchronize cardiovert, if we're to deliver the energy, okay, just without synchronizing it, and we deliver it during the absolute refractory period, what's going to happen? You're right. Nothing. It's not going to absorb the energy. Okay, so the machine, the cardiac monitor, has to time these R waves out. And this will make a lot more sense when we get to SVTs, okay? It has to march these R waves out so when it delivers the energy to reset this rhythm, okay, it lands into the relative refractory period, okay? So the relative refractory periods, okay, and it breaks down into two, okay? this supernormal period is where it's going to probably, it's the weaker of the a weaker normal stimulus can cause depolarization, and so during this period right here, that's probably the best place for this for it to absorb the stimulus, but it can also be absorbed through the relative refractory period. So right here, 2 or 3, this is where this is going to be can be absorbed. That's sort of the spot there that you have to be careful of. In theory, you might remember this. We talked about it before at the beginning of the year. In theory, okay, a 9-volt battery can cause a disruption, because what happened is, if there's a disruption, or this, the heart receives the energy here in this relative refractory period, it can disrupt it. What did it do? To make it go into possible VTAC or ventricular fibrillation, right? You remember those two, right, from CPR. VFib, the most common. So how do you test a 9-volt battery?
Don't you put it in water?
Oh, I don't know about that. What happens if you put it in water?
I thought that if you test batteries if they like float or sink in water or something.
Oh, I think they're all sink. They're pretty heavy.
Yeah, some people drop it, it stands up, or some people lick it.
There you go. A 9-volt battery, you lick it. And if it shocks you, if it tingles your tongue, it's good. Okay? That delivers 0.04 amps. Okay? It's a really, very small amperage. It's not going to hurt your tongue, but in theory, it's enough if it hits your heart during this relative refractory period to cause a disruption in the electrical pattern. Okay? When I was in school, we used to walk down and it was very common, it's just a rite of passage. We would, freshmen, because you can always tell freshmen, right?
Yeah.
They're walking down the hall, and if they weren't walking with their books in front of them, here, freshmen for the longest time walked like this. That's how one way you could tell that they were freshmen. Because if they didn't walk like this, an upperclassman would come along and center punch them in the chest and hit them in the chest like that, really hard. All right? And then the freshmen go, "Ugh," correct? And however, what we really didn't know then, or didn't care, is that that punch, it's called a precardial thump. They used to use it with CPR and witness arrest. Okay, where you took the if I went into cardiac arrest right here, witness, one thing you could come up and do is come, not like from down south, but from here to there and thump me in the chest. That delivers approximately 6 joule watts. Okay. The most common rhythm in cardiac arrest is what? VFib, right. So you have ventricular fibrillation here. You have to defibrillate that, deliver that energy to reset that. We want to reset that to a 0 phase or a systole, correct? We want to go to that when we defibrillate. So we can pick up the natural property of the cardiac cell, and it starts producing complexes which hopefully will produce contraction, correct? Well, that 6 joule watts in theory is enough to reset the heart, okay, to take it out of this defibrillation, reset it into this. Does that sound familiar? Okay, so this is what takes place during this relative refractory period, because when we do a synchronized cardioversion, we want to do it during this relative refractory period. I'll remind you guys of that later once we get there. That's later down the road. Okay. So the properties of the cardiac cell is just this, because we want this when we're over here in this ugly looking V-fib, okay, and we defibrillate and we put the heart back into asystole, or no contraction, electrical, or what you consider flatline, right? We want these properties of the cardiac cell to pick up automaticity. Remember, automaticity, it doesn't require any outside stimulus. The cardiac cell doesn't require any outside stimulus. The next one is excitability. It generates its own action potential. Okay? In order to contract, it conducts and then it contracts. So these are the properties of the cardiac cell: automaticity, excitability, conductivity, and then contractility. All right. Good? Still review? Sort of? I mean, it's been a long time, but should still be reviewed. All right. One reason that this can work is that the heart has its own electrical system, own conduction system. So and this should be reviewed as well. So let's start up here at the SA node. SA node's located in the just sort of the top part of the right atrium. Now these are not contractile cells, okay? These are conducting cells. They only conduct energy. We'll look at this a little bit closer in cardiac physiology, how these cells sort of lay over each other, okay? So in color, these are, you can pick these out if you dissect the heart, because they're a different color. I mean, not like blue, or purple. They're sort of a bland, pale sort of color. They don't contract. They're just conducting cells. Or the way that I like to look at this initially is just they're conducting wires. They're like wires that conduct electricity, okay? And they start up here at the sinus atrial node. It's called the sinus atrial node because of the fact that where it's located and what it produces. Right? See if you remember anything from the first part. Since these are not contracting cells, what don't they have? What don't these conducting cells have that make up this electrical conduction system? Very good, actin and myosin. They don't have actin and myosin in it because they don't conduct. Okay, they're only they don't contract. They only conducting cells. So sinus, when we sinus atrial, so a sinus rhythm, if it's working correct, will produce this P wave. So when this depolarizes, okay, the SA node depolarizes, what's going to take place on the EKG is this P wave. This P wave has a definition, and that's important. The definition of a P wave is important. The P wave is upright, well-rounded, and it precedes a QRS complex. So upright, well-rounded. Remember that well-rounded part. If it's not well-rounded, is it a P wave? No, because it doesn't meet the definition. So in a normal response, once the SA node depolarizes, that hosts sodium-potassium pump, right? That stuff. Once that takes place and we're out of that phase and it depolarizes, okay, it produces a P wave on the EKG. Who remembers what rate? The intrinsic firing rate or the intrinsic depolarization rate? Who remembers that? 60 to 100, right. So 60 to 100 is the normal depolarization rate of the SA node. What is that equal to? 60 to 100. Because it's the normal heart rate of an adult. So 60 to 100 is the normal heart rate to an adult. So the SA node is also known as the primary pacemaker of the heart. It sets the pace, the primary pace of the heart. And if everything works correctly, it's a very regular rate that fires or depolarizes at 60 to 100 times per minute, depending on what kind of activity that we're having. Okay? All right, so it starts off at the SA node, and then what will take place over here, because the two atriums contract together, correct? So you have another line. If you were to draw it over here to the left atrium, you would have a internodal pathway, or a pathway in between. So when the SA node depolarizes, it sort of takes a turn over to the left atrium as well, because the right and left atrium, they will contract together or depolarize together, okay? So you have an internodal pathway that goes over here, okay? But we won't follow that. We'll just follow it down this way. So the SA node depolarizes. It goes down another internodal pathway. It's just an electrical pathway, right? To the AV node, atrioventricular node. It's called an atrioventricular node because it sits between the atrium and the ventricles, okay? On the EKG, it's this part right here, the AV node. It's this, what we would consider the PRI. This interval here because of time, right? One thing that you have to keep in mind, that once this depolarizes, it takes time to get down there, correct? Even though it's very fast, it still takes time. And then on an EKG, measuring across in time, right? So it comes to, this electrical impulse comes to the AV node. Anybody remember the function of the AV node? Okay, that's one, yeah. It's a backup pacemaker. Okay, that's very good. What's the primary function of the AV node? Or junction. You're here at AV junction as well. That's digging on a lot of memory. Okay. Relieve the stress. The AV node, or the AV junction's primary purpose is to create a delay. See the line here? See, that's a delay. That's a delay in time. Okay, now that I gave you that hint, why does it need that time? Why does it need that delay in time?
Didn't you say the SA node takes time to depolarize?
Yeah, the SA node is depolarized. So once we have the P wave, the SA node has already depolarized. But why do we need time? The delay, this delay here. Yeah, that's called, so we have proper filling time, correct? So the atrium and the ventricles can fill properly. Without this time, electrically, this would depolarize, okay? This would go from the SA node straight to the ventricles, straight to the Purkinje fibers, like, and it's done. And it would keep doing that, and there would be no refilling time. We wouldn't have proper refilling time for the atrium and the ventricles. So we wouldn't have proper function of the heart, right? If the muscles don't refill, or the chambers don't refill, then we get a decrease in what? Yeah, okay. Yeah, ejection fraction, or simply put cardiac output, right? We get a decrease in cardiac output. Decrease in cardiac output means what? Decrease in... Yeah. But what's the big thing? Oxygen. Decrease in oxygen, right? We don't get enough oxygen because we have a decrease in cardiac output. So we have to have this delay here. It's a natural delay in order for it to have refilling time. The next thing it goes through is this area right here called the bundle of His. And all that is, all the bundle of His is essentially a bunch of these cardiac fibers all clumped together. Picture it as just a big mesh of wire, individual wires, okay? So it's a bundle of these cardiac fibers, okay? The bundle of His is important because when we get to supraventricular tachycardias, or the SVTs, that's a conduction problem that takes place above. Supra means above. So it's above the bundle of His is where the problem is, okay? But the electrical, it stops here at the AV node and then it goes through the bundle of His. Now, you mentioned it. Here it's the backup pacemaker. So what's the intrinsic firing rate of the AV node? It's less than 60, right? So it's about 40 to 60 is the intrinsic firing rate. What happens here, it's a backup, you're right, it's a backup system, because if the AV node doesn't get a response from the SA node, I mean, it's sitting there waiting. It's waiting for this electrical response. If it doesn't get a response, what the AV node will do, it will depolarize. Because if it doesn't depolarize, then we're not going to get this electrical stimulus or energy to the ventricles to cause ventricular contraction, correct? So it will go ahead and depolarize. This is important in EKG interpretation because it's a whole new set of rhythms, okay? If, let's say we have a patient that the SA node is knocked out, the SA node is not functioning at all, what will be missing? Right, the P wave will be missing, okay? So it's only way that it's the heart is actually contracting is due to the AV node. Now you can have an accelerated junctional rhythm. We'll get into that. So an accelerated junctional rhythm would be a rate above what? 60. Correct. It'd be a rate above 60. Okay? So the normal rate of this junctional rhythm is between 40 and 60. And that's for another day. But we'll get into junctional rhythms. They're really easy to recognize because they don't have a P wave. Either they don't have a P wave or the P wave is upside down, okay? Or the P wave may be over here on this side of the complex. And we'll talk about that another day when we talk about junctional rhythms. But they're really easy to recognize. So in the PCT land, you have to recognize what's normal. So what's normal is this P wave, the QRS complex, and the T wave, okay, at a rate of 60 to 100. If it's below 60 or above 100, doesn't mean that it's abnormal necessarily, but we would have to look at this. So you have what? If it's below 60, what is it called? A heart rate below 60. Bradycardia. Tachycardia, right? So if we have this problem here where we have a rate below 60 or a rate above 100, we just have to look at why that's so. Why do we have this bradycardia? Why do we have this tachycardia? Okay, again, that's for another day. So we have the AV node, causes a natural delay in the response to create really the natural function of the heart to create refilling time, goes through the bundle of His, and then through the bundle, it branches off into the bundle branches. The right and left bundle branch, we'll look at this because we have what's called a bundle branch block. Okay? And it's just where there's a blockage in this bundle branch, and they branch off into all these different branches. It's just not one branch, it's multiple branches. And then it comes down to the Purkinje fibers. The Purkinje fibers are the terminal end to the conduction system. Once the energy, if we're all within normal function, once the energy gets down to the Purkinje fibers, what are we going to have? If everything's working normal. Contraction. Very good. We're going to have contraction once we get down to here. Okay. The ventricles also have an intrinsic firing rate. So the heart has three systems, two backup systems, essentially. The normal system is the SA node. If it's working well, no problem, perhaps, right? Backup system to that's the AV node, 40 to 60. The intrinsic firing rate of the ventricles is less than what? 40. Okay, and this is going to cause it's sort of a last ditch thing. So if the ventricles are the only thing that's firing, it's going to cause this sort of wide looking QRS complex. And again, that's for another day. But it's going to be less than 40. So it's the same way. If the heart rate is too fast, it decreases cardiac output. If the heart rate is too slow, will it decrease cardiac output?
Yeah.
Yeah. It's just not pumping enough blood, right? The too fast, it's contracting too fast, not allowing refilling time. If it's pumping too slow, it's not pumping enough blood out. Okay? Which is going to reduce cardiac output. Because cardiac output, what's the formula for cardiac output?
Stroke volume times heart rate.
Very good. Stroke volume times heart rate. Okay? Stroke volume is, what's the average stroke volume?
70 to 100.
70 milliliters, right? And then you add the heart rate. So if our heart rate is 20, right, our cardiac output is only going to be what? Yeah, it's not going to be very much. Okay? So we're not going to get our normal cardiac output. What's the normal cardiac output? And we have to put it in, it's in liters. It's like 5 to 6 liters per minute, right? So that would be the normal cardiac output. Anyhow, so that's the electrical conduction system. And the rest of the time, when we're looking at EKG interpretation, we're going to be looking at problems with this electrical conduction system. Okay? It's all you have to do to be successful at EKG interpretation is memorize the rules for interpretation. You guys can memorize stuff, right? And so, easy enough. So you just memorize the rules for interpretation. So the rule of interpretation for a sinus, a normal sinus rhythm, okay, is a rate between 60 and 100, right? It has a P wave that is upright, well-rounded, a QRS complex, and a T wave. That's a normal sinus rhythm. So see, that's easy to interpret. Once you know what's normal, then you're able to interpret what's abnormal. All right. So the EKG or ECG, EKG if you're in British, ECG for America, right? So it can tell you the orientation of the heart, how it sits. We won't get into all that because it doesn't really matter that much. The heart sits, and I should have looked this up before, but it sits like at 60 degrees. Don't quote me on that. 60 degrees. It sits at an angle, right, in the chest wall. And the EKG, according to the size of these QRS complex, can give us what's called axis deviation. We're not going to worry about axis deviation. If you look at a patient on the ECG with congestive heart failure, they're going to have an axis deviation because they have that big old stretched out heart, right? But we get an abnormal axis deviation when we lay flat or we lay on our side. It can cause an axis deviation. It's important only in the fact that it's going to change the size of this QRS complex, okay? But it's not going to change the makeup of it. Then conduction disturbances, just like we talked about. If all of a sudden now you don't have a P wave, okay? We won't look too much on the medication in electrolytes. We might pick up some of that in cardiac physiology, but it doesn't pertain to really anything with the interpretation. Then ischemia and infarction, we can pick up infarction from what? You guys remember what do you look at for infarction on the EKG? Which segment? Well, the ST segment. If you have ST segment elevation in one or more consecutive leads, or two more consecutive leads, then you have a STEMI. Okay, so ST, if you have ST depression, then that's where you have ischemia. ST elevation is a sign of infarction. So we'll look at that briefly when we review 12 leads, okay? But again, very important, it doesn't really give you any information about the mechanical or the contraction part of the heart. That is evaluated by the pulse and blood pressure. If you want to look at the contraction of the heart, you can tell that. You can tell if the heart's overworking or underworking. Remember, again, it's been a long time, but we talked about +1 pulses, +2, +3. So if I take and I feel my radial pulse and it's bounding, like I push down on it slightly and I can't stop the bounding, that's a +3, correct? What does that tell you? Working hard, right? But if I can push down that pulse and take away the pulsation, then that's a weak pulse, right? And that's telling you that just that the heart's, it's not working very strong, working very hard, okay? So that's a problem. Then the +2 is normal. We've all applied electrodes, some more than others, with all the little kids, right? You put all those little electrodes on those kids, okay? And what this does is, I think there's a picture, yeah. It gives you a picture of the heart. So when we put the electrodes on there, it's creating an electrical environment. So we have a normal monitor. So a cardiac monitor, just where we're monitoring the electrical activity. It's not a 12 lead. Remember, a 12 lead EKG is diagnostic. This just monitors. So we have 4 leads, correct? There are 3 leads, but typically 4 leads. So what it does is it gives you a picture. It's like taking a little picture of that segment of the heart. And it measures in between these points here. So this would be the red one, right, down on the left leg. So it's going to measure positive to negative. So it's looking across this segment right here. So as it measures this part of the heart, lead 2, which is the most common lead because it looks the prettiest, in lead 2, and lead 2 is going to be where all your rhythms are in this section here, EKG interpretation. In lead 2, it looks like this. It puts everything upright. In lead 1, it flips the QRS complex. So this QRS complex is negative. But if you know that you're in lead 1, then that's normal. Okay? That's why we only look at lead 2. Everything you see is going to be in lead 2. Okay? I used to jack with new paramedics. They put the monitor on, and I'd sneak over there and change the leads, because on the monitor you just push a button and it changes the leads, and it flipped those QRS complexes. And so at one point they had this nice pretty rhythm, and the next time they had this ugly rhythm, and they're like, oh wait, what took place? You know, they're thinking of some catastrophic thing that took place. And it's just that we switched leads. So lead 1 measures from here over here across, and then lead 3 down this way. So you get on the limb leads, you get 3 different. If you have a 3 lead, you get 3 different pictures. Does that make sense? So if we go back to here, you're picking up 3 different views of the heart, 4 different views of the heart. Remember, in a 12 lead, there's only 10 views. They just reuse 2 of the views. That's just trivia. But because there's only 10 wires, right, in a 12 lead, but it reuses 2 of the views. So this is just like taking a picture of the heart. So we look from here across here. What portion of the heart are we looking at? What slice of the heart? Inferior, right? Yeah. The reason that the inferior is so important to look at is that's where the majority of the heart attacks take place, because the heart contracts like this. Okay, so that left ventricle takes about 75% of the workload. It's a real thick chamber, and so it contracts upward like that, pushes the blood up. So lead 2, or the inferior look, is very important. But we have an anterior, a lateral, right? We have different views that we pick up with the 12 lead. But the anterior, so we can look at all these different aspects of the heart. So when we hold it up like this, the 12 lead is essentially looking like this, and looking at the different views. What's one of the views that a normal EKG or 12 lead can't see? You can see inferior, posterior, inferior, lateral, anterior. Yeah, it can't see posterior. It can if you switch the leads around. If you do a posterior 12 lead, that we'll learn about later, you put the 12 lead on the back and you just sort of flip the leads around, it can read posterior. An 18 lead 12 lead can read posterior. Or if you just have the normal 12 lead, you just have to put it on, you apply it to the back instead of the anterior chest wall. So you have the limb leads, okay, the 4 leads, and then the cordial leads, or the chest leads, and those are the V leads. So this standard limb leads is the right arm, left leg, right leg, right? So what do we have? White, black, red, and then green over here. Okay, those are the limb leads. And then the chest leads, the V leads, V1, 2, 3, 4, 5, and 6. Okay, we'll get to that. That's another day. And we'll look at those. Okay, and then this just gives you the direction on what lead. Don't really worry too much about that. You can put a note in there. Don't worry about it, or exit out, or whatever. We know where the leads go. We have to know where the placement of the leads go, and we already know that. So, and then the chest leads. Here are the limb leads, okay, and then the V leads. You will, for your PCT certification, there was questions there that ask you which intercostal space is V1, okay? So put a little note beside this, memorize this, and also the limb leads if you don't know that by chance. But you will need to know how to apply the EKG and the 12 lead. And then there's this is on the right side, but V1, V2, V3, V4 goes right underneath the nipple, and then you have 5 and 6. V6 is mid-axillary. So I find this fourth intercostal space, okay, and put V1 and V2. Then I'll come down, not on a bone or a rib or any bone. Make sure it's in the intercostal space, okay. I'll put V4 because the nipple is my reference point. Then I'll come back up and put V3. Then I'll come over here and put V6 mid-axillary. Then I'll put V5 in between V4 and V6. Does that make sense? Okay. We'll work on that. But this is definitely a memorization thing, this chart here on where the leads go. Alright, everybody good? Good for right now? One more thing and we'll call it good. Okay, let's get through the paper. We've already talked about this a little bit. Remember the EKG paper, across here is time, okay? And this is amplitude. We're in EKG interpretation, we're mainly concerned with time. So what we have is we have big boxes and little boxes. And we actually do that. They like the normal QRS complex is not, it can't be wider than 3 little boxes. Okay? But if you do the math, what is that? Point what? 12, right, 0.12. So a normal QRS complex, by definition, can't be any wider than 0.12, or 3 little boxes. So in time, 1 little box is 0.4 seconds, okay? A big box, can you see there the small and large boxes? Okay, so there's a small box and then the large box. The large box is 0.2 seconds. 0.20 seconds, or 1 large box, okay, in time. This is important because when we get there another day, we're going to talk about, towards the last part, first degree heart blocks. First degree heart blocks, not really that big of a deal, as long as they're asymptomatic, and most of them are, okay. A first degree heart block is a delay in the conduction through the node. So by definition, a first degree heart block is where you have a PR interval, right, greater than 0.20 seconds, or 1 big box. So if your PRI is longer than 1 big box, you have a first degree heart block. See how the rules come into play? And you just have to memorize these rules. They're easier as it goes along, okay? But it's a must to memorize these rules. So you have the boxes. Okay, so a small box in time is 0.6 0.04 seconds. A large box is 0.2 seconds. In amplitude, it's 1 millimeter, or one large box is 5 millimeters. Okay? The millimeters take effect when we do 12 lead interpretation and we're looking for ST elevation, because ST elevation equates to a STEMI, and the patient is having a STEMI when they have ST elevation greater than 1 millimeter and 2 or more consecutive leads. See, it's just to interpret a STEMI is just to know the pieces and parts. We're looking at the ST segment, right? And then we have elevation in millimeters, okay? So, and then 2 or more consecutive leads would be like lead 2 and lead 1, 2, and 3 or something, right? That's not really the way it goes, but we'll look at the 12 lead chart later. But you have consecutive leads, okay? And so it's just a matter of definition. So you memorize the definition and you get used to looking at the rhythms. That's why when you're at the hospital, it's important that you look at those rhythms. You may walk up and interpret like 10 sinus rhythms, okay? But all of a sudden now you go up there and there's something different. So with rhythm interpretation, it has to be systematic. It's a lot like your patient assessment, okay? It has to be systematic. So the first thing that you look at when you look at EKG interpretation, does it have a QRS complex? If it doesn't have a QRS complex, then what doesn't it have? What does the patient potentially not have? Contraction, which equals no pulse. So the first thing that you look at in EKG interpretation when you're looking at it on the monitor, you go in the room and you look at the monitor and go, oh good, they have QRS complexes. Okay? Make sure they have those. Okay? Then you go back and say, okay, do they have a P wave? If they have a P wave and it's upright, well-rounded, then it's a sinus rhythm. Okay? They have a QRS complex and they have a T wave. Now all you have to do is look and see if these all fit within the normal limits. Each one of these have a normal limit on it. Like we talked about the QRS complex, 3 little boxes, right? 0.12. If this thing is wide, if it's one big box, if it's 5 boxes wide, it could be a number of things. But it's considered a wide QRS complex. Now we just have to go and figure out why. Why does it have a wide QRS complex? And so it's just one more step. Okay? It can mean nothing. You can have a wide QRS complex because of a bundle branch block. So it could be completely insignificant, okay? But it doesn't meet the rules for that, for the QRS complex. Okay? Everybody good with that? It's really not as hard as it seems. People who struggle with EKG interpretation, they struggle with the systematic part of it. So I'd come in here and I'd look, okay, QRS complex, good. P wave, good. T wave, good. Then I'd start looking at, is that PRI, is this upright, well-rounded? Is this less than one big box? Okay. Does this have a Q and an R and S, right? And then is the T wave upright? You know. So there's different parts to it, but once you get used to it in a systematic approach, it's fairly easy to do, because you just apply the rules for that interpretation, for that rhythm. All right. We talked about the isoelectric line, that neutral line, right? Biphasic just means both ways, right? because you have upward and downward deflection of these different waves. And then here's what we already talked about: the P wave. Atrial, it signifies atrial depolarization. This QRS complex represents ventricular depolarization, and then this T wave represents ventricular repolarization. What's missing? Right, atrial repolarization. It's missing because of this amplitude of this QRS complex. This has so much energy, let's say, okay, or amplitude, that it hides the repolarization of the atrium. If you could look, the repolarization of the atrium is somewhere hidden in this big QRS complex because it has so much more amplitude than the repolarization of the atrium. It's just hidden there. So you have the P wave, SA node, QRS complex, ventricular depolarization, T wave, ventricular repolarization. We will get into these in another day. If this is peaked, if it's flat, if this is flat, okay? All these tell you something different. The T wave tells you a lot about your potassium. If this, I believe, don't quote me on it, but I think if it's flattened, you have the patient could have hypokalemia. What's hypokalemia? Low potassium, yeah. Low potassium, right? Now, if you have hypokalemia, in theory, then that sodium-potassium pump has a problem, right? Okay. If this is peaked, enlarged, then you have hyperkalemia, right? The same way with here, if this P wave is flattened, then you could have hyponatremia. Natremia would be what ion? Sodium, right? So you can get a lot of information from the EKG, and there's a lot more that we don't necessarily need to go in just basic interpretation. Okay, if this is lengthening, if you have a prolonged T wave or ST segment, right? So there's quite a few things that go in there, but that's the normal. So it's just like a picture. Okay, when we talk about interpretation, I'll give you better your EKG strips on your notes are really small and they're hard to look at. I'll give you another picture, a bigger one, where you can actually see it clearer. Okay, just like any picture, you have to look at it. So if I wanted to memorize what you look like, right, how would I do that? I look at the picture all the time, okay, until I memorized it. I look at that picture and look at that picture, okay. How would I define? How would I define it if it was you? Exactly, the characteristics. So if you kept looking at a picture of me for some strange reason, okay, one of the characteristics that you would look for in me would be what? Besides this gorgeous face.
Bald.
Bald, yeah.
Oh. So you went there, huh? Yeah, you looked bald. You're bald. If I had hair in that picture, you'd be going, huh? Right? Glasses? No glasses? You'd be going, who is that? Correct? You see what I'm saying? So this is the same way. You look at this picture enough, we go, wait, there's no P wave. What's that? it's not the normal. It's not normal. Okay? And that's what you're going to have to do on your PCT certification exam. You're going to have to look at those rhythms and determine that's abnormal. Okay? And then what would you do?
Figure out what's causing it to be abnormal?
No, as a PCT, what would you do? All of a sudden your patient had a normal sinus rhythm, okay, and you went back in there and all of a sudden now they're missing their P wave. That's right, notify the nurse all the time. See how easy it is? Oh wait, your EKG changed. Go tell the nurse, hey, Smith's EKG's changed. They lost their P wave. Okay, then the nurse is going to tell the doctor that, right? All right. So, see how that is? But you have to really recognize the different rhythms. Okay. At some point in time in your medical pathway, you're going to do EKG interpretation if you stay in clinical medicine. So, if you're going to be a doctor, a nurse, a PA, all right, you're going to do EKG interpretation. It's just to what degree? In paramedicine, we do a lot of EKG interpretation because of the fact that we're on our own. Okay? So if a nurse doesn't know what that rhythm is, what do they do? What would they do? They go ask another nurse or a doctor, right? We're in the middle of nowhere. We don't know what it is. We're bad medic. Yeah. So EKG interpretation is a big thing for the pre-hospital medicine because we're sort of out on our own. Now we do have the option of sending it electrically to the hospital, okay? But most of the time we can interpret rhythms pretty easy. And then here are the guidelines. These are important. On your, I said one more thing, I keep going. But make sure that you understand what this is normal. So a normal PRI interval is 0.1 to 2.0 seconds, just like we just talked about, okay? The normal QRS complex is actually 0.2. It says 0.10, but it's 0.2. It's 3 little boxes, okay? And then the QT interval for our purposes is not necessary in EKG interpretation. But you need to know what the normal PRI, because if you have elongated PRI, then it's a sign of a first-degree heart block. A wide QRS complex could be VTAC, okay? So it could be a different rhythm that you're responsible for. And then ST segment, 1 millimeter of elevation. More than 1 millimeter of elevation is abnormal. But that is important. Put a star by that. And then the rest is just, now that we know that what's normal, we start plugging everything else in here, these other rhythms that are abnormal. So if we know that a sinus rhythm, normal sinus rhythm, rate between 60 and 100 with one upright, well-rounded P wave, less than the PRI less than 0.20 seconds with a QRS complex, right, less than 0.12 seconds with a T wave that's upright, well-rounded. So it's just a matter of picking up these, what's norm, what are the norms, what are the abnormals, okay? And the other thing is that you guys can get a job as a EKG tech. You know, so this is the first step to that job as an EKG tech is rhythm recognition. So if you graduated and you went to apply for a job as an EKG tech, they're asking you, well, hey, where did you get your EKG class from? And it won't matter because you'll repeat it in the hospital again. And then you go to work as an EKG tech. Okay? So several different things, but it's not really that difficult. All right? Yeah, we won't worry too much about it being too narrow, just too wide. And again, that's 0.12 seconds for a wide QRS complex. Okay, I really mean this now. One more thing. The J point we talked about when we talked about 12-lead interpretation way back during cardiac emergencies when we talked about STEMIs, okay? So when you go to interpret, is that ST elevation or is that a slope? See, there's a lot of things. This ST segment can actually slope, which wouldn't be ST elevation, it would be a slope. So that a slope could be a sign of early repolarization. Okay, something totally different. So we find the J point, and that's that intersection, see, QRS, right? Where the S wave meets the isoelectric line. Okay? In this J point, if it's elevation, if it's true elevation, this will go straight up like an elevator. It won't slope. It won't have a gradual slope to it. The J point is going to go straight up. We only use the J point where when we talk about interpreting that ST segment. Is that ST segment elevation or not? All right. Any of you guys want to be cardiologists? No? So, I mean, this would be your bread and butter here. When the ER doc can't figure out, is this a STEMI, they call the cardiologist in. They send over to 12-lead. The cardiologist looks at the 12-lead and interprets the 12-lead. There is a lot of information there to look at. Okay, but so that's sort of the next point. See how this is really a normal. See, it's flat. Here's the elevation. It has 1, 2, 3, almost 3.5 millimeters of elevation, ST elevation. So if we were to find the J point would be right here, correct? Where that laser is. So that is true ST elevation. And then here's ST depression, which ST depression typically means ischemia, okay? You could have a lot of ST depression. It may be a non-STEMI, okay? But again, we covered that, but it's not necessary. What we would look for is right here. Because if they had a non-STEMI, what would we follow that up with? If they had a bunch of ST depression, what would we follow that up with? If you were the doctor taking care of them, what would you order? Remember those two lads? That lad? Well, troponin, for sure. You'd order troponin. And if their troponin was elevated, then they're having they could be having a non-STEMI. Okay. A STEMI would go immediately to the cath lab. A non-STEMI, they're probably going to reserve a spot pretty quick for them. Okay. And we've already talked enough about the T wave. What doesn't? We mentioned a couple. Okay. 1, 2. And we'll pick this up when we get into like talking about SVTs, but they measure R to R's. See, this would be a regular. One thing that we want to, when we look at, to be a normal sinus rhythm, the rate has to be regular. It can't be irregular, correct? So it has to be between 60 and 100 at a regular rate. To see if on an EKG, to see if the rate is regular, we would march out these R to R's. We would measure it. So the next two R to R's will have the same distance in between them. We'll see that when we see an irregular rate, that these R to R's won't match. They won't march out. So if you had two more complexes over here at the same distance, then those R to R's march out, or that's a regular ray. Does that make sense, everybody? If you had a two here, and then the next two you had the complex right here, then it wouldn't be the same distance. It would be, it wouldn't march out correctly. Again, we'll look at that another day. Okay, good stopping point here. Most of review, right? A lot of review in that. Questions? Good? Okay.